First of all, I would like to thank HIPRA for inviting me today. I think this venue represents a great opportunity to share with you some new information on Mannheimiosis and Histophilosis in feedlot cattle. Although I'm living in Canada, I come from France, so I do have sort of an understanding of the both systems, and I hope that I will bring some very knowledgeable information today. So my speech today will be divided in two parts. In the first part, I will talk about Mannheimia hemolytica and its role in the bovine respiratory disease complex, also known as shipping fever. More specifically, I will talk about the pathogenesis, the detection, the diagnosis, and the control of bovine respiratory disease. Then, in the second part, I will talk about Histophilus sonda infection and its role in the bovine respiratory disease complex, but also its septicemic form, which is highly prevalent actually in Western Canada. So let's move on to the first part. Mannheimia hemolytica. So, as you already know, Mannheimia hemolytica is the gram-negative bacterium that can reside in the upper respiratory tract of healthy animal as a commensal organism. It is generally accepted that Mannheimiosis or shipping fever starts with the explosive proliferation of Mannheimia hemolytica serotype 1 and 6 in the upper respiratory tract. Then, the bacteria can get access via aerosolized droplets to the lungs, where, depending on the virulence factors and the host defenses, the bacteria can create inflammation and lesion. To be more specific, Mannheimia hemolytica will attach the cells of the lower respiratory tract thanks to virulence factors, its adenosine protein or capsular polysaccharides, and then will release lipopolysaccharide or LPS, also known as endotoxin, and lipopolysaccharide, and leukotoxin, also known as an endotoxin. Lipopolysaccharide will first activate the coagulation cascade, will have a toxic effect on the endothelial cells, leading to vascular leakage and vasculitis, and will activate the macrophages. These macrophages will in turn recruit neutrophils by creating pro-inflammatory cytokines, and those neutrophils also will be activated with leukotoxin. Leukotoxin is a really nice toxin. It has a dose-dependent effect. At a low dose, leukotoxin will activate the neutrophils and macrophage, whereas at high dose, they will create transmembrane pore that will create leakage of the reactive oxygen and reactive nitrogen species, leaking also of lysosomal enzyme and leaking of leukotriene that will create lung lesion, fibrino-necrotic pleuritic pneumonia. If now we go back to the reality and something that is more practical, you can see these cattle do have a fibrino-necrotizing pleuritic pneumonia due to Mannheimia hemolytica. You can see the cranioventral distribution of the lesions and the pleuritis in the cranial lobes, which is consistent with bacteria going down from the trachea. On the cut section here, you can see that we do have actually some distended interlobular space by fibrin or edema, and some irregular foci of necrosis here, and some dark lobules, hemorrhagic dark lobules. When you see that, you're almost sure that it's due to Mannheimia hemolytica. So, it is to note that typically, Mannheimia hemolytica doesn't get access to the lungs and doesn't create disease, thanks to a lot of respiratory defenses that will actually protect the animal, such as the mucociliary apparatus that will constantly trap and remove the bacteria from the lower respiratory airways, or the secretory and cellular defenses like antibodies, macrophage, or others that will also either kill or trap the bacteria. So why do cattle get sick? Cattle get sick because of predisposing factors that will knock down those respiratory defenses. For example, viruses are well known for impairing the mucosal lining of the respiratory tract, so impairing the mucociliary apparatus, and those viruses, especially BVD, are well known for impairing the secretory and cellular defenses. Stress also will create production of endogenous corticosteroids that will also in turn impair the cellular and secretory defenses. And finally, you've got the suboptimal environment, noxious gases, high variation in temperature that will also damage the mucosal lining and the impaired secretory and cellular defenses. So in summary, Bovine respiratory disease results from a complex interaction between the host, the bacterium, and the environment, with the predisposing factors that will tip the balance to favor lung consolidation and the disease instead of the homeostatic states. So none of what we just discussed now is new. Actually, you already know that for years. So the new information concerns more the transmission dynamics of Mannheimia hemolytica during BRD outbreaks. Until recently, most researchers or clinicians were wondering if Mannheimia hemolytica outbreaks or BRD outbreak associated with Mannheimia hemolytica were due to the spread of a highly variant clone among cattle. This is what you can find here, with one animal is shedding a variant clone that will just keep all the group sick, that will create disease, or is those cattle actually are just sharing common risk factors and are getting sick by their own strain with the recrudescence of Mannheimia from the upper respiratory tract to the lungs. To respond to this question, actually I did transtracheal aspiration in cattle housed in the same pen during BRD outbreaks. Then I did a culture to isolate Mannheimia hemolytica, and finally I did strain typing by pulsophill electrophoresis to differentiate those strains between each other. And what I did find is a high genetic diversity of Mannheimia hemolytica. So in other words, most of the animals during BRD outbreaks are getting sick by their own strain, with a little bit of transmission. Our conclusion was then that actually Mannheimia hemolytica mostly recruits from carriers rather than being transmitted between cattle. This finding implicates that the control of Mannheimia hemolytica should primarily focus on the host defenses and not on the bacteria by itself. You know, for example, when you say you have to treat a whole group to protect in-contact cattle against the variant, the spread of a variant strain, actually this is not that true for Mannheimia hemolytica. Cattle with bronchopneumonia are usually detected, at least in Western Canada or in North America, by pen checker that check cattle once or twice daily. They target at clinical signs such as depression, appetite losses, or respiratory changes, like increased respiratory dyspnea, polypnea, increase of nasal discharge, etc. But is this detection early enough? To respond to this question, actually, I equipped last year 560 steers with Riemann temperature boluses to monitor their body temperature continuously, but also 3-axis accelerometers. You can see some of those animals. Actually, that is the pen that I followed, and each animal had a pedometer to monitor their physical activity. And I also placed a line in front of the bunk to monitor their feeding behavior. What we did observe is cattle are pulled, so are detected by pen checker on average 73 hours after the beginning of fever detected by the boluses. So 3 days between the onset of fever and the detection by the pen writer, on average. We also saw that those animals has a decreased number of steps detectable at least 52 hours, so 2 days before the detection by the pen writer. And that finally, those animals already spend a lower time at the bunk, detectable by my system, 41 hours. So to the question, is this detection early enough? I would probably respond no, it's not early enough to really ensure the best treatment response. But is this detection sensitive enough now? We saw the early component is sensitive enough. Over the last 20 years, 7 different studies have looked at the BRD treatment versus the lung lesion at slaughter plants. And what they did found in actually from 37% to 83% of the animal never treated for BRD had lung lesion at slaughter. Based on these results, actually White and Renter recently estimated the sensitivity of pen checking to detect BRD at only 62%. In other words, up to 38% of cattle with BRD are not detected during the feeding period. So is it sensitive enough? Probably not. So how can we improve this BRD detection? Some people that know me already know that I'm really towards monitoring systems, and I think we'll have monitoring systems that will enable us to improve our BRD detection. We already saw that detection in changes in body temperature, or detection in changes in feeding behavior, or detecting in changes in physical activity can all detect sick animal earlier and more sensitively than pen checking alone. However, I would like to emphasize the fact that each of these systems individually today lack of specificity. For example, I showed that up to 75% of the fever episodes detected by the use of rememboluses lasted less than 47 hours without any treatment. So you've got transient hypothermia pretty frequently. That can be due to viral infection only, reaction to the vaccination, or even a successful immune response. Like a kid's, you know, if you put your kids at a daycare, he has a fever for 48 hours, you won't treat it with antibiotic. Cattle are the same sometimes. And also, Wolfger and collaborators from University of Calgary showed that up to 90% of healthy animals had abnormal feeding behavior during the first week on feed. Here's an example of 2 steers that just escaped their pen and are eating in another bunk. So if you're monitoring their feeding behavior, you will have alert on that. So my point is, be careful if you cannot just detect sick animals by fever or abnormal feeding behavior. I know that there is tool on the market, Fever Alert or Fever Tag, that are commercialized and used by probably some of you. I would be pretty prudent on those because, as I showed you, there is a lot of transient hypothermia that doesn't need to be treated necessarily. But the good news is that recently we combined different systems and we showed a dramatic increase in the specificity of detection. So in other words, instead of pulling cattle only based on fever or abnormal feeding behavior or abnormal activity, we combine them. For example, only pull cattle that has fever, but also an abnormal feeding behavior or an abnormal physical activity. And there's tools that are coming on the market, but they are not yet available. So we can talk about that a little bit later. Now, I would like to talk a little bit about the diagnosis. And I will start by the diagnosis of dead animal. In North America, only 48.7% of the dead animal have received a post-mortem examination. So less than 1 dead out of 2 are examined post-mortem. However, necropsy post-mortem examination is crucial for the diagnosis of Mannheimia hemolytica. Why? Because as one of the old practitioners working at my university is saying always, the dead pile never lie, which is really true. For example, when I opened this animal here, and I did observe, sorry for the quality, when I did observe this fatal fibrinous pneumonia with this fibrin here, so you've got a pruritus here, you've got some interlobular space that are widening by actually the presence of fibrin and some very hemorrhagic lobules, I was almost sure that this cattle actually was died of Mannheimia hemolytica because the recent publication showed that in those fatal cases of fatal fibrinous pneumonia, Mannheimia hemolytica is involved in more than 90% of the case. So my message is do as many postmortem as you can, and if you cannot do it, train feedlot personnel to do it, to take pictures, to send you the pictures, and to remotely diagnose those animals. And we can talk about that later on. But I know this is working, and that's what we are doing actually in Western Canada. We diagnose up to 40 cases every morning based on pictures. And this is, in our system, seems to be pretty accurate. So now if we're talking about the diagnosis in live animal, because we also diagnose BRD on live animal, the diagnosis is based on visual sign of BRD, so depression, appetite, and respiratory character change, and an elevation of temperature. The threshold that we commonly use in North America is 105 degrees Fahrenheit or 40.5 degrees Celsius to determine an animal as BRD affected. So this is the threshold that they use. This, as you can guess, is first of all not specific of Mannheimia hemolytica and even not specific of BRD, actually. White and Renter, the same guy that estimated the sensitivity, estimated the specificity of pen checking and treatment at only 63%. In other words, up to 37% of animals are treated for BRD, whereas they are not really affected by BRD. How can we increase the accuracy of BRD diagnosis in feedlot? One solution could be to do an advanced clinical examination. Lung auscultation, for example, for detecting increased breath sounds or abnormal breath sounds. Second option could be lung ultrasonography to detect lung consolidation. There is a recent publication by Rademacher in the US showing that it's a very good tool, but Dr. Padon actually will talk about that later, so I won't cover this part. What I want to say is both techniques are great. However, they require trained people and experienced people, which are rare or even non-existent in a feedlot setting most of the time. Concerning another solution is to do laboratory tests. Nasal swab, trachea aspiration, bronchoalveolar lavage with PCR and culture. That will also be discussed by Dr. Padon and also Dr. Maldonado, so I want to emphasize two more on that. However, what I would like to emphasize is those take time to complete, which is not compatible with the shoot side decision. So I would like to introduce a new tool actually that was recently commercialized in the United States and Canada, the Whisper stethoscope. So it's a computer-assisted electronic stethoscope. How it works, the Whisper auscultation consists in placing the diaphragm of your thermometer, of your stethoscope over the fifth rib of the right lateral side of the cattle, in recording during 8 seconds a lung sound. This lung sound will then be automatically and wirelessly sent to a computer, and the computer will give you a score from 1 to 5, 1 being normal, 5 being abnormal, and it will send back the score on your stethoscope. So you can read directly on your stethoscope, is my animal is normal or not. I do have a stethoscope with me, I can show you the stethoscope. And you'll see that's pretty rapid actually. So here the guy is placing the stethoscope. He will press the button, this is the rec button here, so it will just record the sound, so you see the blue light. So 8 seconds. That's flashing, so that's good. Then it's transmitting the sounds to the computer. That should be shoot side. So this is a typical hospital in feedlots. And here you've got the score, 2, mild acute. So this animal had something that was wrong with his lung, increased breath lungs or abnormal breath. So but my question is, when I saw first the tool, I said, is this accurate? So what I did is, I actually studied 35 steers pulled by pen rider, experienced pen rider, and I had them to, each time they pull one sick, put one healthy pen mate in the same pen. And I did a complete examination on both the thick one and the healthy ones, including lung auscultation, but also aptoglobin, etc. And then I calculate the agreement between the whisper and the veterinary auscultation, and I estimated the whisper sensitivity and specificity using latent class analysis. And what I did find actually is a substantial agreement between the veterinary auscultation and the whisper auscultation. As you can see here, only 8 out of the 70 paired auscultation were discordant. In other words, most of the auscultation were positive on both or negative on both. And when I calculated the accuracy, I found a sensitivity of 92%, 93% and a specificity of 90%. However, you can see those wide credible interval because we do not have a very huge sample size. However, based on that, we concluded that this tool has the opportunity to substantially increase the specificity of BRD diagnosis in a feedlot setting. And that has not to be used by a vet. This has to be used by feedlot personnel to improve their diagnosis because they are the ones that are responsible of the treatment on a daily basis, not us. So if you look at that, here, the sensitivity, the specificity of a cowboy alone is 63%. If you interpret pen checking plus the whisper afterwards, you can increase the specificity to 96.1%. So a drastic increase in the specificity of BRD detection. In the concept, in the context of reduction of antibiotic use, that could be a nice tool to use. Now, let's talk about the control. Clearly, the best way to deal with BRD is to prevent it. I think we all agree on that. As we saw previously, predisposing factors are tipping the balance to favor lung consolidation and disease. BRD prevention is meant to do intervention strategy to restore this homeostasis. And we have 3 main types of intervention strategy to prevent BRD: antibiotic use on arrival, vaccination, and reduction of risk factors by an improved management. Here is just some numbers about what is going on in the US. More than 90% of the cattle are vaccinated on arrival. I'll talk a little bit about vaccination also. But they also received, in the big feedlots, 71.5% receive antibiotic on arrival injectable. So the use of antibiotic is widespread, and I think won't finish tomorrow. We should face it, antibiotic injectable antibiotic works on arrival. That works. Repeatedly, numerous studies have shown that use of antibiotic on arrival, macrolides or even tetracycline, reduce BRD morbidity, BRD mortality, increase average daily gain, and increase the carcass quality, especially in what we call the high-risk BRD calves. However, it is no longer acceptable in Europe, and I do understand that, and I think it's important. It's an important move to do, but that will be discussed by other speakers, not by me. Concerning vaccination, in North America, all or most of the cattle are vaccinated on arrival with modified live vaccines containing IBR, BVD type 1, type 2, PI3, and BRSV. In addition, they're also, most of them, vaccinated with bacterial component, bacterial vaccines, including Mannheimiosis, Pasteurella multocida, plus or minus also H. somni. I'll talk about H. somni on the second part of my presentation. Although the timing of vaccination, so on arrival when the cattle are stressed, is not optimal, Larson and collaborators recently did a meta-analysis based on 18 different clinical trials showing that actually vaccination with Mannheimiosis plus or minus Pasteurella multocida can significantly lower the risk of morbidity in feedlot cattle. Here is the forest plot, and you can see that most of the risk ratio, the relative risk, are lower than 1, which means that it's protective. So there is an impact on the morbidity in those animals. Furthermore, they showed that cattle that are vaccinated against bacteria, so Mannheimiosis plus or minus Pasteurella multocida, do have a lower mortality. So I'm quite confident, based on those data, to say that vaccination, bacterial vaccination, works and can prevent BRD morbidity and mortality. And that's why they're doing it, because in feedlots, if it's not working, they will know that pretty well and won't use it because it's not cost effective. The last, and probably the best way of preventing BRD, is to improve management to reduce risk factors. And it's by spreading stress over various periods of time. And it's also by developing an immunity through vaccination prior cells and this high stressful period. So this is called preconditioning. Preconditioning, more specifically, is based on weaning calf prior to transportation, at least 45 days or few weeks. Dehorning and castrated calf. I know that castration is not really a problem here because we fed bulls, but in North America they feed steers. Training calf to eat from a bunk or eat from and drink from a watering station. And finally, fully vaccinate animal prior to transportation. And if you do a good preconditioning program, if you reduce the risk also associated with transportation and stuff like that, you can have a BRD morbidity lower than 5% without any antibiotic treatment on arrival. I'll take the example of one of the feedlots that I'm working with. It's a natural feedlot. They enter 7,000 head of cattle in less than 4 weeks. Those cattle are coming from Saskatchewan, Alberta, so they are traveled more than 1,000 kilometers from some of them. They all arrive at the feedlot. They don't receive any antibiotic, and the morbidity is between 1 to 5%. And at the moment, it's below 2 and 3%. And there is snowstorm also in Canada. So this is doable, and they manage it. So I'm a big believer in preconditioning, but I know that this industry, it's complicated, but I think that as vets, we should promote that. So my key message of this first part is, first of all, that Mannheimiosis causes a fibronecrotic pneumonia because of its leukotoxin and LPS. Those two bacteria, those two variance factors are amazing because LPS are recruiting neutrophils and macrophages, whereas leukotoxin are killing them. So that's why they create such nice lesions. Mannheimiosis outbreak are mainly due to predisposing factors and not to the spread of a highly virulent clone. Detection of BRD is neither sensitive nor early, but new systems are coming soon. I know that there's some systems in the US and even in Europe that are coming, but be careful on the specificity of this system, because if you have too many false positive detection, the farmer will go away, or won't use it. Post-mortem examination should be performed as often as possible. I will show you a video of how we do PM post-mortem in Western Canada. You'll see it's not that complicated. It can be done pretty fast in the field. Clinical diagnosis is not specific. And finally, Mannheimiosis vaccination and preconditioning can significantly reduce morbidity and mortality. Histophilosis somni infection and BRD complex and septicemia. Histophilus is, like Mannheimia hemolytica, a gram-negative bacterium from the Pasteurellacea family that can reside in the upper respiratory tract, but also in the genital tract of healthy animal as commensal organism. It is nevertheless important to note that some strains are more virulent than others. It can invade the upper and lower respiratory tract and create disease. I will go back later on that. Can also invade the genital tract, especially of female, leading to vaginitis, endometritis, and abortion. And these strains can also invade the circulatory system, creating a septicemia with second localization in the brain, creating thrombotic meningoencephalitis, in the heart, creating a myocarditis, in the pericardium, creating a pericarditis, pleuritis, and the joint, creating polysynovitis. The lesions, so in summary, we've got three forms: the reproductive form, systemic form, and the respiratory form. I won't talk more about the reproductive form because my talk focus on feedlot cattle, so reproduction is not really an issue. So I'll focus on those two others. The lesion created by H. somni are mainly due to one virulence factors, the lipo-oligosaccharide. So it's like the LPS, but it's LOS because it's shorter, that's all. Poly and oli. And these virulence factors will be responsible for adherence and apoptosis of endothelial cell, creating a vasculitis. The exposure of the basal membrane will activate the coagulation cascade, leading to thrombosis, and will trigger the release of pro-inflammatory cytokines and the recruitment of neutrophils. Here, you've got typically an image of H. somni lesion. Here, you've got the thrombus just here. That is in the vena, but it's not very good definition. Here, you've got the endothelium also that is pretty affected, so vasculitis, and you will have hemorrhage all around with a lot of neutrophils. So this is typically lesions. So vasculitis and thrombosis are the landmark of H. somni infection. But H. somni also can release histamine, leading to vasoconstriction and edema, can create biofilm, which will increase its resistance against antibiotic treatment, and also have the possibility to resist killing by the macrophage, the monocyte, and the PMN, and also undergoes antigenic variation, like mycoplasma, for example, which make it difficult, actually, which can enable him to evade the immune defenses pretty well. Let's now go back to the lesions and the clinical presentation. The respiratory disease, in the respiratory disease form, what we do observe very currently is the laryngitis, here also called diphtheria. There's not always necrophorum, Fusobacterium necrophorum that is involved here, but we can have also pure culture of H. somni in this kind of lesion. Also, H. somni will create fibrinous suppurative bronchopneumonia, as indicated here. In a recent study, sorry, the table is a little bit small. In a recent study that looked at the pathogens by PCR and culture, so PCR is on the top and culture on the bottom, of 68 lungs of cattle dead of fibrinous pleural pneumonia in either Alberta, Nebraska, or Texas. What they did observe is more than 90% of those lungs had Mannheimia hemolytica isolated by PCR, detected by PCR. But also, if you look at this line, which represents H. somni, we do have 57% of the lungs that were also positive for H. somni, which means that H. somni is prevalent in the BRD complex or the shipping fever complex. What is also interesting is if you look down, here it's the H. somni isolation by culture, as only 15% of the lungs were positive by culture, whereas 57% were positive by PCR. So I won't talk more about the detectability of H. somni, but that could be a reason for why we don't find H. somni more often, because culture have a lack of sensitivity, and I think that will be covered by Dr. Maldonado a little bit later. If we go back now to the septicemic form, it can create thrombomeningoencephalitis. Here you see a lesion just here. You can create a pleuritis. Most of the time you've got a pleuritis with no lung lesion below. That's why we differentiate a pleural pneumonia versus a pure pruritus, fibrinous pruritus, and polysynovitis with a lot of fibrin in the joint. It can also create a pericarditis, acute myocarditis. Here, I would like you to look at those lesions here, such as acute myocarditis lesion. I will show you a video, then we'll see those lesions. Or acute myocarditis of chronic here, you've got fibrosis, and here the papillary muscle is sort of expulsed from the heart. And that type of lesion, actually we can see them pretty often. Because there is no recent paper on the H. somni epidemiology in the literature, I did a query of the H. somni associated mortality in 6 Western Canadian feedlots from the Feedlot Health Management System database. That represents from 2011 to 2013. That represents 186,000 calves. And I look at the H. somni mortality. You can see that the mortality is quite different from one year to another, and also quite different from one feedlot to another. Feedlot 5, for example, less than 20% most of the time. Feedlot 6, up to 1.2% of mortality in all the foal-placed calves. So in total, H. somni represent 0.48% of the cattle placed in feedlots, which represent 25% of the total mortality, which is about 2%. So H. somni is a big issue in Western Canada. The main lesion observed actually is myocarditis. In more than 50% of the case, the lesion that we do observe is the myocarditis. What is important to note is that we also observe animals with different type of lesion. They can have diphtheria, myocarditis, polysynovitis, and a bronchopneumonia at the same time. But myocarditis is really a key lesion, and this is in agreement with previous studies that reported actually that there is less and less thrombotic meningoencephalitic form of H. somni and more form of myocarditis. And that is already reported in 1990s, a real switch between thrombotic to myocarditis. I just put this slide. So DOF is days on feed, just to show you that H. somni mortality actually occurs mainly after 5 or 6 weeks on feed. So with the mean at 66 days on feed. So H. somni mortality is not concomitant from BRD complex per Th. Some authors actually reported that cattle first developed a BRD, and then H. somni will create the septicemic form, leading to those fatal lesions that we do observe at necropsy. Detection. So in its septicemic form, it is, I would say, difficult, if not impossible, to detect sick animal, at least in a feedlot setting. And most of the cattle are just found dead in their own pen. Only 19% of the cattle of the database that I showed you, so it's 1,000 animals that were dead, out of those 1,000 animals dead, only 19% received the treatment prior to be found dead in the pen. So detection is pretty difficult. So you can easily understand that the diagnosis of H. somni is mainly based on necropsy. And if you want to get a good diagnosis, it's really important to look at the papillary muscle. So I would like to show you this video. I hope it won't shock people. It's how we do PM in Western Canada, so we can discuss about that later. So that was 4 weeks ago. It was minus 15, and I had at this feedlot 12 postmortem to do in less than 1 hour because after I had a surgery to do. So just to show you how it works. So first of all, what we do is we dislocated the coxofemoral joint. Then I open the stifle. What I'm looking at the stifle is either presence of fibrin or arthritis. Actually, there was a little bit of fibrin, so it's really important to look at the fibrin and see if there's flocculent material inside. Then, hop, yeah, it's 5 minutes. It's a real-time situation. You can see it's not really professional video neither. So we open the cattle like that, always on the left, on the side, to not be bored by the rumen. Otherwise, you cannot have access to the gut. So it's really important to have a sharp knife and a sharp axe too. So you'll see my axe is not that sharp actually. Yeah, sharp knife is really key. So here I'm just opening a handle to start with my axe. I'll show you that later. We also remove each time the trachea. So we are looking at the larynx to see, as I told you, lesion of diphtheria. But we also looked at fibrinonecrotic lesions in the trachea. Why? Because IBR is also really present in those feedlot settings. It's a good way to detect that. So, yeah. It was not sharp anymore. You can see that I'm wearing gloves below those because it was really cold. So there's a little bit of diphtheria on this one, but not that much. And then I'm taking a quick look at the esophagus, but it is to know that the esophagus actually is not the best way to find BVD case. You know, we look at that for PI and lesions, but the pair patches and the ileum is way better to detect BVD animal than the esophagus. And then this is the best part. The axe. Okay, a little bit barbarian, I agree. And my axe was not sharp at all, so I was not really happy for the video, but because it was a good case, I keep it. Okay, this is barbarian, but it works pretty well. And when you're good with an axe, you know, the old vets, in 2 sways of the axe, they open the thoracic cavity. 2 sways. They just foot. That's pretty impressive. I'm not very good at that. So here you'll see it's getting more interesting. So you can already see there that there is a consolidation here, consolidation in the intermedial lobe here. So consolidation is really when you palpate it. That should be normally it's a lip. The consistency of the lung should be like the lip, and as soon as you've got consolidation, it is more like the nostril. So here you see that consolidation. We always do also 2 cuts: one in the caudal part, one in the medial part, and one on the last part, and one on the cranial part. So what I'm doing most of the time, I'm also pressing the lungs to see if there is pus coming out because of the purulent, suppurative bronchopneumonia that I do to Pasteurella multocida. That's why we differentiate grossly the lesions. We do have what we call fibrinous pneumonia and suppurative bronchopneumonia or chronic pneumonia. So here I'm looking at that. But actually it was a little bit suppurative, but not that much. And here I open the pericardium. So look at the heart. The heart is looking fine it's not bigger. There is no signs of edema, nothing, no sign of heart failure, but you'll see the surprise. So it's good that it's just after lunch. So here I open the papillary muscle. Really important to open the papillary muscle. If you want key message, if you want to find Histophilis, you have to open those papillary muscle. And here you can find here, look at that, those here. There is lesions of myocarditis on both sides. Here I will do a better zoom. Sorry, no professional video, clearly. But here, you can see here, that's pretty obvious, here the acute myocarditis. And this cattle, the story of this cattle, it was, I think, 45 days on feed, found dead in the pen. So by doing my necropsy, what I did find is a little bit of fibrin in the joint, a little bit of lesion also on the larynx, and this myocarditis. Based on that, I did actually some culture on these animals. That was H. somni. And each time we find those lesions, it's pathognomonic of H. somni. And there's one report in the vet record, actually, in UK in 2007, when they had 4 cattle dead, and they finally PM'd the 4th one, and they did find also this myocarditis due to H. somni. So we can have H. somni also in Europe. This is reported. So please open the heart when you do have a sudden death, because you can find that type of lesion, and if you find that, think about H. somni. We can also diagnose in live animal, but that I told you, they're always found dead in pens. So that will be covered by actually Dr. Maldonado and by Bart. The last part of my presentation is the control of histophilosis. In Western Canada, there is 5 histophilosis somni vaccines that are commercially available. And I would say that more than 80% of the high-risk cattle entering the feedlot are vaccinated against H. somni on arrival. Although those vaccines are widely used, I must admit that the efficacy remains uncertain today. Why? Because there are no recent studies, if you look at the literature, on the field efficacy of H. somni vaccines. Only old vaccines and nothing really new. And furthermore, all the cattle are vaccinated on arrival, but they are still dying of H. somni. However, it seems that vaccinated cattle are dying less often from H. somni lesion than non-vaccinated one. And if you look, for example, at the publication by Rebel in feedlot with, I think he has 200,000 calves, so a huge study, it actually showed a reduction of 17% of H. somni associated mortality in vaccinated cattle versus unvaccinated cattle. I know that is not politically correct to say that, but also a good way of managing outbreak of histophilosis in Western Canada is to use antibiotic massively. So what we do is a pulse of the pen. We use 1 gram of tetracycline per head per day during 3 days. And that is a good way of preventing mortality when we do have, for example, acute case. If I open 2 cattle from the same pen with those acute myocarditis, what should I do? Should I say detect those animals? And we know that they are just found dead in the pen. So I don't have the choice. I think pen treatment is good when you don't have a good detection. Here it's difficult to detect. So prevention with vaccination and sometimes pen treatment when you do have a high mortality. That's why I wanted to talk about that. My key message are that H. somni actually is frequently involved in the bovine respiratory disease complex, at least in Western Canada, that they cause numerous lesions other than BRD. So don't think only at BRD, numerous lesions, so thrombotic meningoencephalitis, but also myocarditis. And there's really this switch that we did observe in North America. Also that H. somni is a big problem. I told you the 0.48% of all the full-place calves are dying from histophilosis in my sample. So it's representing, as I told you, 25%. And there's report that each H. somni represents up to 50% of the total mortality. The diagnosis is often based on postmortem examination, at least in feedlot cattle. So please inspect the papillary muscle. Do as many PM as you want, as you can. And we can talk about those digital necropsy, but you can train people to take pictures and you can at least find a lot of stuff based on pictures afterwards. And finally, H. somni vaccination could reduce mortality associated with H. somni infection. However, I think we need further research now to confirm this statement also with the new vaccines, because all the information available in the literature are with the very old vaccines. So thank you very much for your attention.